Do you guys want me to go ahead and jump in and open it up, or are you looking for somebody else to start?
Oh, I'm just letting people connect here.
Oh, perfect.
Looks like they're coming in. So hello, everyone. We're just giving it about a minute here for everyone to go ahead and connect in. So thank you for joining us today. So my name is Jessica Geschke, and I'm with Wisconsin Voices for Recovery, and we have several people on who are going to be speaking today. We have Megan also with us, who I don't think anyone's really seen before. She's always hiding. So she's here. She's playing West today. But we're going to go ahead and get started, and we have our folks from Rogers on. We're really excited and so grateful to have both Dr. Maloney and Dr. Nelson here with us today. So they're going to go ahead and we're going to do things a little bit different. So those of you who have been with us the last several weeks, we just do our typical Q&A, and we've had individuals talking, to us face to face. But this time, Rogers, they're stellar. They've put together an entire PowerPoint for us to talk about their programs. So we're going to go through the PowerPoint first and have them explain things, and then we'll open it up and do some question and answers. So while we're going through the PowerPoint, if you guys want to take down any notes, and that way we can answer those questions for you at the end. So first, Dr. Maloney serves as the Executive Director of Addiction Services for Rogers Behavioral Health. And we also have Dr. Nelson with us as well. And she is the educator who directs the clinical services for Brown Deer campuses of Rogers Behavioral Health. So thank you both for joining us today. We are so excited and pleased to have you. And I will go ahead and turn it over to you.
Sounds good. I'll go ahead and jump in then. So as Jessica kindly noted, my name is Melissa Nelson, and I am the Campus Clinical Director here in Brown Deer. I'll explain a little bit more about what that means, and then I'll just go ahead and jump into the presentation today. So specifically, I work at our Brown Deer campus. I collaborate very heavily with our other campuses in the local area as well. I have a heavy role over our inpatient programs that includes both adolescents, adults, for both mental health and co-occurring or addiction services, and then provide a lot of collaboration and support with our PHP and IOP programs within the clinic. So that said, we wanted to share a little bit about what addiction services at Rogers has looked like, particularly over the COVID pandemic, how we've been able to adapt and ensure that we're still continuing really high quality care. So first, a little bit about Rogers for those who may not know much about us or our history. Rogers has been around for over 100 years and actually is a pretty large organization with almost 2,500 employees. That includes 160 medical staff and over 90 psychiatrists. In Wisconsin, we have 3 inpatient hospitalization programs in Oconomowoc, West Allis, and Brown Deer. We have 14 residential programs, all of those within the state of Wisconsin in either Oconomowoc and West Allis. We have 20 outpatient centers and 40 plus unique programs within those outpatient centers at either partial or intensive outpatient levels of care. And those outpatient programs are across the US as illustrated on the map. And what partial hospitalization means for us is individuals who are seeking treatment typically about 6 hours a day, Monday through Friday. There's some slight variances program to program in terms of hours. And our intensive outpatient programs are 3 hours a day. So at Rogers, we don't do the typical outpatient services, meaning like you meet with a counselor or provider once weekly. We tend to have higher levels of care. In terms of our service lines offered, so in other words, these are kind of like what our specialty programs, they fall under these umbrellas. And that's OCD and anxiety, programs specific for individuals who have both autism and a mood disorder or an anxiety disorder, eating disorders, depression and other mood disorders, addiction services or co-occurring services, and trauma recovery. And then last but not least, emotion dysregulation. And so we're going to really be honing in and focusing on our addiction service lines and the co-occurring treatment that we provide. So in terms of how COVID has impacted our normal day-to-day functionings for us as an organization, as with everybody, it's had a pretty significant impact. At our inpatient and residential levels of care, we continue to be open. We continue to have the same capacity to serve patients. We have not decreased our number of beds or our utilization of services. So we are open. We have made some modifications to programming. So some examples of that include Patients and staff are now masked in all patient care areas. We have smaller group sizes to ensure that we can adhere to social distancing norms. We've modified how we use our physical space a bit within the hospitals to ensure that we can continue to ensure the social distancing is followed. For our PHP and IOP programs, these programs have been converted entirely to telehealth. I will note that we have been really, really fortunate as an organization to have a lot of extra abilities to ensure that patients can access these services, even if they may not have the materials necessary. So for instance, we do have a couple of folks that come on site to do their PHP and IOP services if they may not have a safe environment in their homes, or they may not have the necessary technology. We also have worked with some families to get them the necessary technology to them to ensure that we're not limiting access to services despite these pretty unpredictable times. So I want to talk a little bit more about like what these telehealth services look like, given there's a pretty wide array in terms of how folks are using telehealth right now. So for us, we provide all of our telehealth through a virtual treatment modality. And what this means is that individuals join us via video teleconferencing. We use Teams as a platform that is HIPAA compliant and secure. These services are available to children, adolescents, and adults from home or, as I mentioned, on site. And all of our patients thus far have been able to note that they've been very easy to access. They do require internet connection and a device that is audio video capable. Again, we will work with patients if they do not have these technology means. That said, patients receive all of their care through these platforms, and this includes individual sessions, group work, consults with their psychiatrist or other members of their treatment team, family sessions, etc. So they're receiving the same quality of care and the same services that they would get face-to-face, just via a virtual platform, which I'm ahead of myself. So as noted, these are kind of the core components that are included within each of our programs, and all of these are replicated in a virtual environment for us. So with that, I will pass it off to Dr. Maloney to talk a little bit about some of the substance abuse programming specific applications.
Good afternoon, everyone. So as Melissa Nelson mentioned, I'm Michelle Maloney, and I'm the Executive Director of Addiction Services, and that's just sort of a fancy title in that I live and breathe substance use treatment at all of our locations. And, you know, one of the key components really about substance use treatment, and certainly amidst the opioid crisis that we're continually seeing, is urine drug screens, and how we have switched our urine drug screens to oral swabs. From that perspective, we will still use a urine drug screen depending on, you know, kind of the hotspot. You know, if a person is in a, you know, hotspot area, we'll limit. If they're near a Quest lab, we'll send them there, or they may come into the clinic for urine drug screens, but most of us have moved to oral swabs. And basically what that is we have patients, we mail them to the patient's home, and they will put the swab in their mouth. It takes about anywhere from 2 to 5 minutes, and we have a telehealth session with them and the nurse or our physician. And during that time, they will read that swab result over the telehealth. So it's been able to really help us continue to determine patients' use, particularly as the provider's looking to prescribe medication, which brings me to the next point regarding our medication services. So we are using and we are continuing to prescribe medications during this time. We're doing in-home induction of buprenorphine if appropriate. Some of our providers are providing, 3 to 7 days of medication at a time. If they're, more stable and they're in our IOP, they can do 30 days of medication. And when appropriate, we're moving towards more, longer acting medication options, such as either Vivitrol or Sublocade. And so we do continue, those services during this time. Melissa, can you move to the next one since you have the screen?
Sorry about that.
One of the other things that we really want to continue to doing is certainly continue our collection of outcome data from self-assessments. In our addiction service line, we use the QIDS to determine depression because we certainly know that that's a post-acute withdrawal. We use anxiety scale ratings to look at their anxiety, making sure their anxiety is going down. We look at quality of life. And then for addiction, we also look at the UDIS so that we can measure cravings, see where their cravings are at, as well as the BAM, which is the Brief Addiction Monitor, which was really designed to use in treatment to see if patients are making progress and utilizing them within the treatment plan. So we are continuing to collect that outcome data and sharing that with the patients to improve their treatment plan and that coordination. We are looking at some research at the current time that Rogers is starting regarding the data of our telehealth versus our in-person outcomes to ensure that it's still quality treatment. We are collecting patient satisfaction and we've shifted some of our questions to their satisfaction with telehealth, their satisfaction with the technology, whether or not they believe they're making progress. And one of our unexpected findings is we're finding that our attendance is actually quite higher in telehealth than in our in-person treatment. And there you can see 95% attendance, and our inpatient rate was 90%. Some things we did not necessarily anticipate when we launched our telehealth is what we see on camera. And we have seen some interesting things on camera. I think it provides us certainly a great opportunity to really get a sense of the patient's family dynamics. We have seen increased exposure to substances. So, we've heard in the background for some where a family member has asked another family member to get them a beer at 10 o'clock in the morning. We have seen patients where they'll have family members having sexual relations in the background. We have also been able to truly see, what's going on in a patient's home that they may or may not have told us about previously. We've also seen, particularly in some of the other areas of the country, a lack of drug availability. Both from a medication perspective, but also from the illicit drugs and the availability of alcohol. So, we've had some where we've been told the patients can't get alcohol, that the stores are out or there's no way for them to get it. So we've seen a lot of substitution from their drug of choice to another substance. And I think as we talk about, addiction, in the past, addiction equaled, isolation, or isolation equaled addiction, and really recovery was about connection. And so really helping them build those healthy connections, even in the midst of the current time that we're in. So that's really why we've, recommended a lot of different apps for our patients. We do a lot of 12-step meetings or other meetings online, and we really provide a list of meetings for patients to join virtually, as well as connecting them to alumni. Again, just looking for opportunities to build some healthy connections so that they can stay connected, and really reinforcing the stages of change and that they have a choice as they continue to go throughout their day and throughout their treatment. As I mentioned previously, we are looking to do some research. We've started research regarding the use of telehealth with substance use because there is a literature gap out there, as there's not a lot of research regarding substance use and the use of telehealth. There is also research currently coming out, was released by Harvard this past week, regarding COVID and chronic marijuana users, as well as individuals who smoke and use vaping. What they're finding in the initial studies is that substance use patients who do use, nicotine, vape, marijuana, smoke crack, they're more susceptible to COVID. And if they contract COVID, their outcomes are poorer at this time. And they do believe it's because of the compromised lung condition, which, makes sense on the surface, but it's still very preliminary research. But it is something to also educate your patients about in that regard. And this is just a list of the online meetings that we're using with some of our patients. There are a lot of other meetings out there. These are some of the 12-step ones that we're using, and we're happy to share this information with you if you would like. And then the next slide is just really the recovery apps that we're using and that we're encouraging patients to use as appropriate for themselves, again, as a way to stay connected to others during this time. And so with that, I'll, put it out there for any questions, comments that either Melissa or I can answer.
So thank you guys so much. We did have a couple of questions in the chat. And I know that Janet, who's also with Rogers, was answering some of them, but I do want to open that back up for discussion because I feel like this is something that continues to be a struggle in Wisconsin, and I feel that it's asked over and over and over, and it's not a treatment provider issue or an entity issue. This is a Badger Care issue. So the question came up as to when Rogers will accept Badger Care for residential treatment. And I'm not sure if Janet or Kim, if you want to comment on that.
Sure. Again, I kind of talked about this in the chat a little bit, and just trying to explain that Rogers certainly accepts Badger Care for our inpatient services, our intensive outpatient, and our partial services, which Dr. Nelson explained is up to 30 hours a week. Unfortunately, currently with Badger Care in the state of Wisconsin, they do not cover residential services. So it's not that Rogers Behavioral Health won't accept Badger Care for residential. It's a benefit that currently Badger Care in the state of Wisconsin is not covering. So I do often have family members call, and just also trying to, continue to educate, especially with other states, because it's interchangeable when we say inpatient and residential, and what does that mean, and what those average lengths of stay look like. So just to clarify, because it can get confusing when someone's looking for inpatient treatment, inpatient within our system is a very short length of stay. It's either for crisis stabilization, typically our average length of stay can be up to 5 to 8 days, and then for withdrawal management, 3 to 5 days. So those are our lengths, and Badger Care will cover that. And then of course, for our residential services, we take the majority of all commercial plans. So I hope that answered the question.
I also see, do you know how long telehealth will be covered by insurance companies as the requirements have been lifted for COVID? And the answer is it's somewhat variable. Our utilization review teams have been working very, very heavily with insurance companies to make note of any individuals that those telehealth companies or insurance companies have set firm deadlines of when they're going to stop covering telehealth services. And so we already, within our organization at least, have a full committee working across all the different levels of care to look at what does it look like to come back from telehealth services as well, because we want to be ahead of that to ensure that there aren't any patients that don't get coverage through insurance companies because of this telehealth benefit. I will also note that our organization has been working very, very hard to ensure that individuals who would typically have had their insurance company cover our services and their insurance companies are refusing to pay for telehealth right now, our organization is taking that up to be able to engage in those conversations with the insurance company and ensure that that's not a barrier to our patients getting care. In regards to extra training for changing into a telehealth environment, we have had the fortune of actually having pre-existing telehealth services at some of our PHP and IOP sites, particularly within our regionals, that might share doctors across locations and campuses and things along those lines. And so we had some pre-existing telehealth resources and training that we had developed internally that met the requirements for our physicians and providers to gain the necessary telehealth training. So all of our clinicians that are providing telehealth have had quite a bit of additional training, but we've offered that internally and in-house. So I unfortunately don't have a lot of good external resources. I know that there's been several organizations that have offered or discounted their telehealth training. So like, for instance, I know PESI has a 16-hour telehealth mental health services training that they have comped for free right now. So while that's not a Rogers resource, just figured I'd throw that one out there.
And to add to that, Melissa, I think we also, we've manualized and standardized our treatment either, even prior to telehealth.
Yeah.
We've been able to take that standardized material, share it with our patients, either through electronic communication, or we've mailed out some of that materials to patients' home that we've been able to use to truly engage them. We've also broken that down into activities as well as some PowerPoints, again, depending on the different service lines and within the addiction treatment. We've taken cravings and broken it down and used videos and different activities to engage individuals, because 6 hours can be a lot at different times for an individual to sit in front of their computer, if you will. So we want to make sure that we're truly engaging them. And I think, to our clinicians' credits, they've been doing a phenomenal job, which shows in our, attendance records and really the patient's engagement levels.
Yeah, and echoing off of that, I would also note one of the things that we've been able to really lean into is utilizing the home environments, given that the individual is surrounded by it. So typically within a PHP program, for instance, where you're in treatment for 6 hours a day, your exposure to the same environments that are very stress-inducing is pretty limited. And so individuals, if anything, have a hard time transitioning out of a treatment environment where they've got a lot of added protective factors surrounding them. And so we've had a lot of conversations about how do we utilize the fact that we're able to do treatment while they're still in their home environments for a lot of patients, to ensure that we can address some of these systemic factors. We can get individuals to generalize the skills that they're learning in treatment in the moment in their homes. And so that's been a really cool thing to see, not only within our addiction programming, but across our lines of services.
Just a quick question, if I may.
Yeah, absolutely.
Yeah, Jack Rose from NAMI, Kenosha County, and also on the Kenosha County Treatment Court. Can anybody talk on the swabs versus UA as far as the different testing? Pluses, minuses?
So, the plus to the oral swabs, you can do them via telehealth, so that, you're able to get that read right then and there, and the physician or the nurse can read that. So that's certainly a plus. The negative of an oral swab, it is more costly for, than a POC urine drug screen. From an adulteration perspective, both can be adulterated. So they're kind of even in that way. The oral swab, you could argue, has less bodily fluid, that's being done that way. So again, if you're looking at evaluating POCs, I think the oral swabs are certainly advantageous during this COVID time and during the telehealth perspective. So it allows patients not to have to leave their home and can, be safer at home in that regard.
If you would, just go through the procedure. Say you're
Oh, okay.
going to give an oral swab to me right now.
Sure. So you would break open the box and take the oral swab out of the container. You would put it in your mouth and you would chew on it for about 2 minutes. Once you've chewed on it for about 2 minutes, you put it back in the container and screw the lid on. And then after about 2 minutes, there is a line that will show up to read the alcohol. And then after about 2 more minutes, you will see other lines for opioids, buprenorphine, marijuana, THC, methamphetamines. So we are using a 12-panel oral swab.
And what is the difference in the cost?
The oral swabs range anywhere from $5 a POC on up. Urine drug screens, typically speaking, if you're buying in bulk, can be anywhere from like $3.50 on up.
Okay, thank you. And one other thing, is it possible to get a copy of the slides from today's presentation?
So this entire PowerPoint will be posted on both our website and the Wisconsin Voices for Recovery website, as well as our Facebook.
Thank you.
Mm-hmm. Any other questions?
Hi, Tim Wood from Promise You Sober Living. I'm just wondering, I get quite a few male potential residents from West Dallas, Oconomowoc, Harrington. And when they call me, they're usually not calling through a social worker or their counselor, and they're just telling me, I'm positive I don't have COVID. I want to come and live with you in our men's facility. And their verbal enthusiasm just does not satisfy our requirements to coming in. Are you seeing any COVID in your facilities? I mean, I've had 2 calls today, and I've spoke with them, and they just assure me they're healthy. Well, I try to explain to them you can feel healthy and still have the COVID. We at our facility have kind of cut things in half where we don't have roommates anymore. Everyone has their single rooms. I was way ahead of this process before, our mayor or our governor or whatever, to keeping a clean and safe environment. And so far, no one in our house has had COVID. What assurances can I have that, and I guess I know the answer to that, there are no real assurances I have about taking, most of these guys are calling me from a 3 to 5 day detox. If they were coming from Harrington, we'd have more of a track record of, what their health has been for the last 28 days. And I asked them to have their counselors give me a call. I never really hear from anyone. Most likely they are already discharged and gone. So I guess I'm wondering, what are you doing? Are you just doing observation for potential COVID infected people, or you're not doing any testing there, are you?
No, I can jump into at least the inpatient and residential levels of care in terms of what we're doing for screening as well as maintenance. So all patients that admit to Rogers are screened for symptoms upon admissions, to include fever, as well as any recent development of cough, etc. And those screenings are pretty comprehensive prior to coming in. We also assess whether or not they have any known exposures to individuals that have tested positive for COVID. That said, patients are monitored daily with vitals being taken to ensure that as soon as any symptoms arise, that we are meeting those necessary standards to ensure that that spread isn't happening. Given that all of our patients and our staff are masked at all times within our care facilities, that also helps us to mitigate risk. In regards to whether or not we're testing. No, we are not doing testing. However, we are transferring individuals out for testing on an as-needed basis.
Okay, thanks a lot. I appreciate that. I used to be a nurse at Rogers as well, so I know you're doing as much as you possibly can.
We're trying.
Yeah. God bless you all.
Any other questions or comments? Okay. Well, thank you both so much for joining us, and thank you for the rest of the Rogers team for being present today. We are so grateful to have you guys, and just for your knowledge and all the expertise, and for everything you're doing for those in the community that struggle with substance abuse. So thank you all for coming.
Thank you for having us. Stay safe.
Yes, thank you guys.
Thank you.
Thank you all. Bye-bye.
I know.